Namaste everyone and welcome to pre-course module of second BNB knee course to be held on 28th and 29 July 2017. And I'll be talking about concept of anatomic ACL reconstruction. I'm Dr. Binod Sheshan from NAMS National Trauma Center and my moderators are Dr. Amit Joshi and Dr. Naveen Kumar Karn. The exact incidence of ACL tear is not known. However, it has been estimated that around 200,000 ACL tear occurs in a year in US. Out of them, around 100,000 of them undergo surgery each year. The reconstructions methods can be extra-articular or intra-articular, which is again further divided into open or arthroscopic. Based upon the philosophy, it can be an isometric or anatomic, which can be obtained by either two-incision technique, a transfemoral technique, or transportal technique. Over the last decade, reconstruction of the ACL has evolved from a surgical technique in which the objective were isometric femoral tunnel placement and avoidance of the intercondylar notch roof impingement towards an anatomic surgical technique which attempts to restore the anatomy of the native ACL. In isometric ACL reconstruction, because of the verticality of the graft, though it was able to resist the anterior-posterior translation, however, it was poor in resisting the rotational movement. That's why many of the surgeons now have shifted from isometric to anatomic ACL reconstruction. So, what is anatomic ACL reconstruction? Van Eyck et al. Define the anatomic ACL reconstruction as the functional restoration of the ACL to its native dimension, collagen orientation, and insertion site. Remember, the anatomic ACL reconstruction is a concept. It is not a specific surgical procedure. Since the anatomic ACL reconstruction is a concept, not a specific surgical procedure, this concept can be utilized in single bundle ACL reconstruction, double bundle ACL reconstruction, remnant preservation ACL reconstruction, and augmentation of the partial ACL tear. Not only that, it can be applied in the revision ACL surgery as well. There are four principles of anatomic ACL reconstruction. The first principle is to restore the size, shape, and orientation of the native ACL attachment sites. The number two principle is to restore the functional bundles of the native ACL. Number three principle is to restore the native tensioning pattern of each ACL bundle. And the fourth, but not the least, principle is individualize the surgical procedure for each patient. So why do we need an individualized surgery in ACL? It is because of difference in anatomical characteristic of each patient. Every patient is different and every knee is different. So every patient should not get the same operation. The surgical technique is dictated by the ACL injury pattern, whether it is complete tear, partial tear, whether the remnant is present or absent. It also dictated by size and shape of the native attachment sites. This may influence the graft choice and graft preparation. Also dictated by size of the intercondylar notch and degree of rotational stability. Why do we need to perform an anatomic ACL reconstruction? The goal of performing an anatomic ACL reconstruction is to reproduce the anatomy of the native ACL as closely as possible. And it has been proven biomechanically and clinically that anatomic ACL reconstruction better restores anterior tibial translation, rotational stability, and normal knee kinematics compared to non-anatomic ACL reconstruction. And it has been hoped but not yet proven that by restoring more normal knee kinematic, the anatomic ACL reconstruction technique will lead to better clinical outcomes as well as decrease the incidence of osteoarthritis after ACL reconstruction. Our first principle of anatomic ACL reconstruction is to restore the size, shape, or orientation of the native ACL attachment sites. To achieve this principle, the placement of tunnel is critical. And the anatomic ACL graft placement in both femoral and tibial side is critical to the success and clinical outcome of ACL reconstruction. Now, among these two, the femoral tunnel is more important because of length tension of the graft. ACL graft is mostly influenced by the position of the ACL femoral tunnel. The identification of the femoral insertion site and placement of the tunnel within the native ACL attachment site is important. Once a surgeon is able to successfully locate the ACL attachment site, then it is a matter of choice of philosophy as to where the bone tunnels are placed within the attachment sites. Some of the surgeons have advocated to place the tunnel eccentrically, which will give rise to more isometric graft, whereas the general consensus is placing the graft on the center of the ACL femoral footprint. Biomechanical studies have demonstrated that center-to-center placement of single bundle ACL reconstruction is more effective at controlling anterior tibial translation and the combined motion of the anterior tibial translation and interior tibial rotation, and restores knee kinematic more closely to that of the normal knee compared to isometric ACL femoral tunnel placement or the anatomic ACL tunnel placement or technique that have traditionally restored predominantly the anterior medial bundle fibers. So, how to get there to the exact location of the femoral footprint, and what surgical techniques allows consistent anatomic ACL femoral tunnel placement? So, there are various techniques to get there. The number one is outside in drilling technique. The number two is transportal drilling technique, and number three is transtibial drilling technique. All of them have their own merits and demerits. However, the common consensus now is the transportal drilling technique is the gold standard for achieving anatomic femoral insertion sites. Here I will be describing about transportal technique. The proper placement of the arthroscopic portals is a critical part of performing ACL surgery, and the anatomic ACL femoral tunnel placement is facilitated by using three arthroscopic portals. These are high anterolateral portal, high anteromedial portal, and accessory medial portal. And this accessory medial portal is placed around 2 cm medial to the medial border of the patellar tendon, just above the middle meniscus. This slide is to show you that when viewing from the anterolateral portal at 90 degree of knee flexion, it gives a surgeon a tangential view of the ACL femoral attachment site, which compromises spatial orientation in shallow deep direction. Whereas viewing from an anteromedial portal gives the surgeon a face-on view with accurate orientation in both the high-low and shallow-deep direction. Hence, for the viewing of the ACL femoral stump, the anteromedial portal is preferred rather than anterolateral portal. Proper placement of the accessory anteromedial portal is critical to the success of the procedure because it is the most important factor affecting the length of the ACL femoral tunnel. The medial lateral placement of the accessory anteromedial portal determines both the length as well as the shape of the aperture of the ACL femoral tunnel. Let us see that if we place our accessory medial portal more medial than the indented side, then what will happen? So it will give rise to perpendicular orientation of the drill bit in respect to the lateral wall of the notch. Thereby, it will give rise to a short tunnel length and circular sepate tunnel aperture. And lateral placement of the accessory anteromedial portal will give rise to increased obliquity in respect to lateral wall of the notch. Hence, it will give rise to a longer tunnel length and elliptical shaped tunnel aperture. After proper establishment of the arthroscopic portals. Now our job is to identify the native ACL femoral attachment site. So what are the methods available for that? So we have a clock face reference method, native ACL footprint method, the lateral intercondylar and bifurcated ridge method, the arthroscopic ACL ruler method, the intraoperative fluoroscopy, and computer assisted or navigation method. The clock face reference method is not preferable because it ignores the depth of the intercondylar notch, and there is no agreed upon reference position for 3 or 9 o'clock location. It relies on no anatomic landmarks, and it is not useful when viewing from the anteromedial portal. The second method is native ACL footprint. In most situations, there are remnants of the native ACL present to aid with anatomic ACL femoral tunnel placement. The center of the ACL femoral footprint can be estimated using the eyeball technique and the location marked with an angle microfracture awl. The eyeball technique is fairly accurate for estimating the high-low position of the tunnel. However, it should be kept in mind that due to parallax that occurs with the use of 30-degree arthroscope, using visual cues to locate the center of the ACL femoral attachment site tends to result in tunnel being positioned more shallow than the true center of the attachment site. The true center of the ACL attachment site can be more accurately located using a ACL ruler. Here I will be demonstrating the method of marking the center of the femoral ACL footprint. The first video demonstrates that by the use of radio frequency ablation, we can mark the center of the femoral ACL footprint. I'm sorry the video quality is not very good because of the technical reasons. Anyway, I hope you will be able to understand some of it. In this second video, my viewing portal is anteromedial portal, and I'm working through the accessory anteromedial portal. I have been putting a sheath of a 4.5 millimeter reamer to the point where I previously marked with the radio frequency ablation. On top of this, with the help of this, I'll be inserting guide wire directly onto the marking which I made with the radio frequency. The other technique is to identify the lateral intercondylar and bifurcated ridge. When there are no remnant of the native ACL, the underlying bony morphology of the ACL femoral attachment site can provide useful anatomical landmarks to assist with the anatomic ACL femoral tunnel placement. The lateral intercondylar ridge is supposed to be present in around 84% of the patients. It marks the upper limit of the superior border of the ACL femoral attachment site, whereas the lateral bifurcated ridge is said to be present in around 48% of the people. It separates the attachment site for the AM and PL bundle. It is important to remember that because the cross-sectional area of the PL and AM bundle is variable from patient to patient, the location of the bifurcated ridge when present does not necessarily represent the true center of the ACL femoral attachment site. In this picture you can see that the lateral intercondylar ridge limits the upper margin of the ACL footprint, whereas the bifurcated ridge separates AM and PL bundle. The important point is that when we divide the lateral notch into 100%, the upper 60 to 65% of the lateral notch is above the lateral intercondylar ridge, whereas remaining 30 to 35% of the wall remains below the lateral intercondylar ridge, and in this area of 30 to 35% there is a femoral ACL footprint. The other method is ACL ruler method. Use of an ACL ruler allows the surgeon to individualize the location of the ACL femoral tunnel based on the specific anatomy of the patient. This allows for patient-specific surgery to be performed versus one-size-fits-all surgery associated with the use of offset ACL femoral femurs. This technique is particularly useful for revision ACL surgery when there are no ACL remnant present and the bony landmark may have been destroyed by prior nasplasty or a previous ACL femoral bone tunnel. To mark the center of the femoral ACL footprint with the use of ACL ruler, the first thing we have to do is to slide the ACL ruler along the lateral wall of the notch until the tip of the ruler contacts with the proximal margin of the articular cartilage. This will accurately align the ruler at the correct starting point, and the length of the side wall of the notch is measured to the point where the ACL ruler touches the shallow margin of the articular cartilage. An angle microfracture awl is inserted into the intercondylar notch through the accessory anteromedial portal and used to mark the location of the center of the ACL femoral attachment site. In this slide, on the right side, lower right side, you can see that the length of the lateral wall is around 18 millimeter, and the awl is placed at around midway between 8 and 9 millimeter, which is around 45 to 50% of the measured distance from the deep proximal articular cartilage border to the shallow articular cartilage border. Anatomical studies have demonstrated that the high-low position of the center of the ACL femoral attachment site is located around 7.3 to 8.6 mm above the inferior articular cartilage border. This position can be achieved by positioning the tip of the microfracture awl midway between the lateral intercondylar ridge or the superior border of the ACL footprint and the inferior articular cartilage border. The other method is use of an intraoperative fluoroscopy. The use of an intraoperative fluoroscopy is the most accurate method of determining and evaluating ACL femoral tunnel placement. This is particularly valuable when in revision cases where there are usually no remnant of the native ACL present and the bony anatomy of the ACL femoral attachment sites have been altered or removed by prior notchplasty and the previous ACL femoral tunnel. And fluoroscopy is also extremely helpful when attempting to preserve remnant of the torn ACL or performing an augmentation technique for the partially ACL tear. In these situations, identification of the lateral intercondylar and bifurcated ridge is not feasible, as this would require rejection of an intact ACL fiber to expose the lateral wall of the notch. The ruler technique is also not possible since the intact ACL fiber prevents accurate positioning of the ruler along the lateral wall of the notch. So, using fluoroscopy, the proper placement of the ACL femoral tunnel can be easily accomplished without the need to rely on remnant of the native ACL or measurement along the lateral wall of the notch or any bony anatomy of the ACL femoral attachment site. When using intraoperative fluoroscopy, the grid system described by Bernard and Hartel is used to locate the center of the ACL femoral attachment site. This method is easy to use, reproducible, and independent of the knee size, shape, and the distance between the X-ray tube and the patient. So, the knee is positioned at 90 degrees of flexion and an angled microfracture awl is positioned at the chosen ACL femoral tunnel location. And the true lateral radiograph is taken. Now, we have to draw a tangent to the roof of the intercondylar notch along the Blumenstadt line. Then again we have to draw two lines perpendicular to the first line. one at the intersection of the tangent line with the shallow border of the lateral femoral condyle, and the other with the intersection of the tangent line and the deep border of the lateral femoral condyle. After that, we have to draw another line parallel to the Blumenset line and tangent to the inferior border of the condyle. And measurements are made as percentage along the Blumenset line, that is line T, and which represents the maximum sagittal diameter of the lateral femoral condyle, and the line H, which represents the maximum intercondylar notch height. The Bernard and Hartel grid has been used to locate the center of the PL and M bundle in human cadaveric specimen. Using data from these studies, a weighted average position for the center of the ACL femoral attachment site can be calculated. This calculation reveals that the center of the ACL femoral attachment site is located at the point which is 27% along the Blumenset line and 34% of the height of the intercondylar notch. Using a grid system described by Bernard and Hartel, we can actually identify the center of the anteromedial bundle, center of the posterolateral bundle, and center of the ACL depending upon the calculation. The anatomic tibial tunnel placement has been less studied and less described than femoral tunnel placement. When we rely on a footprint, the tibial tunnel is placed in the center of the native tibial attachment site in anterior-posterior direction, in medial and slightly medial to the midline position in the mediolateral direction. We can use a reference points. In anterior-posterior position of the center of the tibial attachment site, in most knee is usually 2 to 3 mm anterior to the posterior border of the anterior horn of lateral meniscus, and in mediolateral direction is medial to the midline, distance between the medial and lateral intercondylar tubercles, and these are around 7 mm anterior to the PCL. In this video I am trying to demonstrate you the exact position of the tibial footprint, and normally I use the elbow hammer. Here is the anterior border of the footprint, and I'm marking the posterior border of the anterior horn of lateral meniscus, and I go right medial from that line towards the medial spine, and I come to the center, and just medial to the center I mark with the hammer, and since this is an elbow hammer, the exit point will be around 2 to 3 mm anterior to the line extending from the posterior border of the anterior horn of lateral meniscus to the midline. You can see that in the second video I am trying to demonstrate you the relation of PCL with the exit point, which is around 7 mm. Since I don't have a ACL ruler, I am using a disposable ruler. Similar to the femoral tunnel, we can use intraoperative fluoroscopy to mark the correct placement of the ACL tunnel as well. So for that we need to take a X-ray and the lateral view. And for the soft tissue graft, which will be centered along the axis of the guide pin, the tibial guide pin should lie approximately 4 to 5 mm posterior to the Blumenset line. For bone patellar tendon bone graft, the tibial guide pin placement can be approximately 2 to 3 mm posterior to the Blumenset line, since the patellar tendon graft fibers are offset from the bone block and will come to lie posterior to the axis of the guide pin. The position of the tibial guide pin can be more accurately determined using the method of Amish and Jacob. The medial joint line is marked by the dotted white line. The Amish-Jacob line, which is a red line, it passes through the posterior corner of the widest part of the medial tibial plateau, which is square posterior border parallel to the medial joint line. The anterior tibial cortex represents 0% and the posterior tibial cortex represents 100% of the sagittal width of the tibia. The tibial guide pin position is calculated by dropping an orthogonal line, which is a green line, from the point where the tibial guide pin crosses the medial joint line onto the Amish-Jacob line. The distance from the anterior tibial cortex, that is 0%, to the orthogonal projection onto the Amish-Jacob line, the blue line with the arrowhead, is calculated as a percentage of the total length of the Amish-Jacob line. The tibial guide pin in this case is located at around 44% along the Amish-Jacob line, which places the guide pin in the center of the ACL tibial attachment site. And in the coronal plane, the tibial tunnel should be centered around 47% across the width of the tibial plateau from the medial tibial cortex. Now, to conclude my talk, the anatomic ACL reconstruction is a concept, it's not a specific surgical technique. And individualized surgery is key for performing anatomic ACL reconstruction. And this anatomic ACL reconstruction is applicable for single bundle, double bundle, augmentation, remnant preservation, and even revision cases. The anatomic single bundle ACL reconstruction refers to reconstruction in which the femoral and tibial bone tunnels are positioned within the native ACL attachment site. And anatomic ACL reconstruction better restores rotational stability compared to non-anatomic. Transportal technique is currently the method of choice to achieve anatomic tunnel placement. Thank you all for your patience hearing, and I would like to see you all in the second BNB knee course, which is going to be held on 28th and 29th July 2017. Till then, see you. Bye.